Thank you to the Immunisation Coalition for inviting me. I apologise, my voice is a bit croaky. I've just had COVID, so I might cough a little bit. The great thing about travel medicine is that it's a bit of a light subject. And people tend to think, oh, you know, give people a few needles, they'll be fine. There's actually quite a lot to it. And I just wanted to run through today how I approach travel medicine. And it does say in your program about the inbound traveller, but I'm not talking about the inbound traveller, just the outbound traveller. And my conflicts of interest, I've given talks for various people and written a book, which is really good. You can get it online. And I run a travel clinic. Now, this will be a bit of a whistle-stop tour, of course. And I just want to point out one thing, which probably you've all figured out. Most of general practice, you have the patient come in and you ask them all these general questions and you sort of wander around to try and get the diagnosis. Travel medicine is really different. You have the diagnosis. A person comes in and says, I'm going to Bali. And then it's about management. It's a quite different consultation process. And in travel medicine, you must be systematic. If you're not, you're buffeted like the winds or like a leaf in the stream. You're thrown about all over the place. People come in with questions, and if you don't keep them on track, you need to kind of hold the little hand and walk them through the consultation, because otherwise they're diving off into malaria. And what about dengue? And what about food? And unless you have a systematic process, you'll forget things. And there's a lot to kind of go through in a travel medicine consultation. So being systematic is terribly, terribly important. And the other thing I really wanted to point out is travel medicine is not just vaccines. And of course, vaccines are terribly, terribly important, but don't let that be the whole consultation. Make sure that you think about the other things. There are hazards which travellers can be exposed to that they just won't think about. In a medical setting, we're used to disease, but for most people, it's a bit of a shock that there are other diseases out there. So there are the really terrible places. And everyone kind of figures out this is bad. This is a fridge in Nepal, and you can imagine the meat inspectors are not very busy. And this is a functioning operating theatre in China. And you look at the bucket on the bottom right-hand corner. So there are hazards out there that people just do not expect. We have a marvellous public health infrastructure. In many countries, they don't. This is washing the gloves in India, and you can see the wall there beside the sink. And the beautiful travel brochures that the travellers read and have in their minds when they come to see you means that the brochures don't say about diseases. So people think travel medicine is just, oh, a few shots, go to the doctor, it'll be okay. You mustn't buy into that. But it's very easy to. The tropical islands look nicer on the website. This stuff really happens, of course. And this complacency you have to have in the back of your mind all the time, because you're trying to counter that. If you look at where the travellers actually even come and see you, it's actually quite small. Only about 30% will go to the GP. A lot of them get their advice from the man at the pub, the person at the travel agent. The travel agents don't want to tell you bad things. Oh, no, it'll be fine. I went to Bali. It was not a problem. Their friends will tell them stuff. So try to, I guess, gently guide them into the fact that just because only 1 in 100 people get sick, you don't want to be the one. You know, this is a rare disease, but terrible. They looked at who actually did have a pre-travel consultation. And as you got older, people were a bit more careful. People going to known high-risk destinations, like the picture with the coffins, and VFRs were less likely to have travel advice. So what happens is people come in and they say, oh, by the way, just while I'm here, I'm going to XYZ, do I need anything? And if you can train your reception staff to try and get these people to come back and make a special time, that makes such a big difference, because you cannot do travel medicine, you know, in between the pap smear. Now, there are these incidence rates, which this is a very dense slide, but they have lists of which diseases are more common in travellers. But it's a bit hard to really put that risk into an individual person. And if you look here, the two that I've highlighted, animal bite with rabies risk is much more common than hepatitis A. And yet we're all worried about hepatitis A. Yes, come in. Everyone walks into a travel clinic should have a hepatitis A vaccine. But really, we need to stop thinking about hepatitis A quite so much and start thinking about rabies risk, because that's, as Sarah so beautifully pointed out, is one of the big problems. So what I want to do is run through all the vaccines in a kind of systematic fashion and show you how I approach it. Everything starts with the history, and of course we're doing the seminar, the workshop later on. You need to know where they're going, what they're doing, have they been before, have they got any previous vaccination records, have they got any significant past medical history, what medications they're on. And if you can get the reception staff to tell the patients, you know, when you come for your appointment, bring your details of where you're going, it makes a big difference. Otherwise, you're sitting online going, now this is an intrepid trip, whereabouts does that go? You need to know what activities they're going to have, what accommodation they're likely to have, what food they're going to have. This just helps you guide your assessment of risk. And of course, if they're needle phobic, which we think about 20% of the population are, they're the ones that probably don't even come in and see you because they're so worried. It'll be fine. I don't need to worry. Having international vaccination books has in the past been marvellous, but their popularity has crashed recently because all of a sudden you can get it all online, which is actually a marvellous, marvellous bit of progress. And I would encourage you all to put every travel vaccine that you ever give on to the Australian Immunisation Register, and any old vaccines that are not on the register, please make someone have time to actually put them on as well. This is a wonderful, wonderful resource that's going to become more useful as time goes by. So having this immunisation register is great. And it was really ignored up until COVID. We actually were not allowed to put travel vaccines on there. This was just insane. No, you can't put hepatitis A on there. That's not a baby vaccine. Now, of course, everyone accepts that all the vaccines go on there. And so it's actually better than having little yellow books. It is possible to do serology if you're not sure about what person's vaccine history is like. You can do serology for measles. That's quite useful. Mumps serology is not that useful because if it's negative, the vaccine isn't actually very good. And if you do a mumps serology and it's negative, they'll feel compelled to have a mumps vaccine, which is of dubious value. Rubella is certainly a good idea. Varicella, definitely. Hepatitis B has its own problems. And hepatitis A, if you're going to test, it's only useful for disease. If someone is vaccinated against hepatitis A, they often have quite low levels of antibodies. And so their hepatitis A test might be negative, even though they are adequately protected, because the tests are calibrated to disease, not vaccination. The levels of antibodies for hepatitis A vaccine can be quite low, but still protective. So this is how I approach travel medicine. We give everyone a copy of this book and we work through all the different vaccines. So we work through polio, tetanus, et cetera, so that nothing gets forgotten. And then we do a little schedule and says, okay, these are the ones you're having today, next week, next month, etc. And that provides a bit of a structure to the consultation. And I mean, you can prepare this kind of grid with best practice and so on as well. So I thought it's always interesting to have cases. So I thought I'd have a case here today of Kiara, who came today for her routine 6-month vaccines. And by the way, in 4 months is going to India for 8 weeks, and they're just going to visit family. But it turns out that they're going to visit family in a village wedding with lots and lots of visitors, and who knows who's coming and what their state of disease is. So the first thing is polio, and Sarah has presented these figures very nicely. We try and encourage a lifetime booster dose of IPV. If someone's having an Adacel, we'd say, look, if you're going to a country which is an outbreak, maybe it's a good idea to have a polio vaccine. If you're going to an outbreak, you may need to have a polio vaccine a bit more frequently than as a lifetime dose, but 1 lifetime dose is enough for most travellers. And of course, our little Kiara's already having that as part of her childhood vaccines. Tetanus, you need to ask about tetanus. It often gets forgotten. People need to have had a tetanus within the last 10 years. If they're going into areas where the tetanus vaccine may not be available, it might be better to be within 5 years. If they're going trekking in Nepal and so on, they get an injury that's quite deep and dirty. It's not easy to get a tetanus locally. And of course, diphtheria is still present in many parts of the world, popping up now and again, and pertussis and whooping cough. I've had patients catch whooping cough on planes besides the person who sat next to them coughing all the way. Now they've probably got COVID. So the normal childhood vaccines includes many of these things. You're all familiar with that. And this is the grid that I prepared. So you can see the child's having polio, tetanus, pneumonia, and hepatitis B. That's the routine stuff. Now, measles, this is a big issue. This is actually the most important thing I'm going to tell you during this talk. If you have a child between 6 and 12 months of age that's going to a high-risk destination like India, they can't have their measles vaccine until they're 1. So they're going to be completely unprotected. And it's possible to give kids an extra early measles vaccine between 6 and 12 months of age to protect them for that trip, even if they're going to New Zealand. And if you can give them that extra one, it requires a bit of counselling from the parents because, you know, do I have to get another one? Will this replace the earlier one? But it's very important to give them this extra dose because measles in these children is very dangerous. And of course, in many countries, measles is given earlier, but in Australia, there's virtually no measles. So we don't bother giving a vaccine at 6 or 8 or 9 months of age. So think about that if you've got your VFRs, particularly going into village weddings. And you can see the number of cases is going up a little bit as Sarah has presented. So regardless of destination, this is the Hobbit House in New Zealand. You still need to get that measles vaccine. And they still get their routine at 12 months. So there's that extra MMR, and ideally you give it a month or so before they go. Child's living in about 4 months. So there's that extra one. Now, the next one is chickenpox. Now, unfortunately, Kiara's too little to have any extra chickenpox, but it's amazing how many people, particularly the ones that are up to about 25, have actually not had a complete chickenpox course. The course for chickenpox is 2 doses, and often they've only had 1, and so they need to get that second chickenpox vaccine, or they may never have had the chickenpox disease or vaccine at all. So it is important to check that routine vaccine that they're covered for that. And this is the information now. You need to receive 2 doses. It used to be 1. They said, oh, 1's enough, off you go. They did that with measles as well. 1's a dose, 1's enough, off you go. And then they said, oh, actually, oops, no, we need to give you 2. And we've had discussion about shingles, so I won't go through that again, but I think it's a really good opportunity when you're going through that list to mention shingles. I would have no hesitation about giving people a shingles vaccine for a trip. Sometimes it's pretty stressful. Planes can be delayed by 12 hours. Things can be pretty hot and uncomfortable on some trips. It's not as glamorous as the brochures would have us believe. And I think the important thing is value. From my perspective, travellers are coming in, they're spending $20,000 on tours. $300 for a shingles vaccine is peanuts compared to the misery of having shingles, particularly where they can't get access to any medications when they're away. Flu, we've already discussed. I won't go through that again, except to say that we really need to encourage that. We need to think about that as a travel vaccine because it is particularly bad if they catch flu on their lovely trip. And we've talked about cruises. And we've also talked about the general effects of flu vaccine, so I won't go through that. But it does reduce the risk of all-cause death by 50%, so that's pretty compelling. So we're going to give her a flu vaccine. And ideally, you give children who've never been vaccinated 2 doses, 1 and then another one in a month. And you try and get that in as soon as you can. This child is 6 months, so you add that to the 6-month vaccines. And then we've got typhoid. Generally speaking, travellers that are eating rough are going to be needing to have a typhoid vaccine. Typhoid is particularly dangerous in VFR children and people who are going to be living kind of rough, eating more adventurously perhaps. And there are now oral vaccines for typhoid, which are very popular. The oral typhoid vaccine, if you give them 4 doses instead of the packaged 3, it will cover them for 5 years. So it's worth writing the script for that extra dose. So they have the day 0, 2, 4, 6, Monday, Wednesday, Friday, Sunday, and that will then cover them for the 5 years for typhoid. Whereas the injectable only lasts you for about 2.5 years, the polysaccharide vaccine. Chiara's too small for typhoid, although it is something we worry about with kids. Hepatitis A, very important. We've kind of talked about that already. We don't vaccinate kids under the age of 1. It's possible to vaccinate kids under the age of 1, but it's just generally not needed because they don't get particularly sick with it. But if you've got a 1 or 2-year-old that's travelling and they're going to come home and play in the playgroup with all the little buddies, if they did get hepatitis A, they wouldn't be terribly sick, but they could give it to all the other kids in the playgroup, including the caregivers, which was not going to make the parents very popular. So it is something to think about for kids once they get over the age of 1. And certainly any traveller should have hepatitis A to get on a plane. So we've put a question mark as to whether you would give a child of this age, but I personally would not. Meningitis ACWY, we all know about the funded ACWY given at 12 months. It is possible to give the vaccine early. It's not very popular, but if you've got kids going into very high-risk environments where there's not much access to medical care, it's worth considering having meningococcal ACWY. Also for young people up to about the age of 25, if they're travelling, if they're going to be doing a lot of partying, living in dormitory-style accommodation, it's worth considering. And then, of course, there's the meningococcal belt, which people are familiar with. So we think about giving her an extra meningococcal ACWY because of her remoteness. Once again, this is not funded. It's something you need to discuss with the parents. And from early 2024, we'll have the free meningococcal B vaccine, which will be very welcome. It's sorry? In Queensland. In Queensland, yes, sorry, in Queensland. Go Queensland. But even if they're not getting it for free, it is certainly something to discuss with them because it is a disease which is devastating and the vaccine is available. And I think some parents really want it. Certain nationalities I found love these vaccines. They come in, all their friends have had it, they want it. Other nationalities are not so fast. I think there's something in these mothers groups that they all talk to each other. But you see we're adding vaccines to the schedule. Yellow fever, we need to give for these countries here. Sarah's presented that very nicely. I won't go through that again, but you do need to have the little yellow book. It's the only reason now that you need the yellow book to get in and out of the yellow fever countries. And there's a way of thinking about vaccines where we talk about required, routine, and recommended. And people do tend to fixate on the required vaccines. Oh, doc, it's not compulsory. Why would I bother having it? You know, if I don't need to have a hepatitis A vaccine. But I say to them, the required vaccines are designed to protect the locals, not to protect you, the patient. They only care if you bring disease into the country. They don't care if you get sick. So if you want to be safe, you need to have the recommended vaccines. And of course, routine vaccines are very important. That's been raised a few times during our talks today. There is a vaccine called Dukoral, which is said to give protection against E-tech diarrhea. Now, it's not very good protection. It's mainly 25% effective. But for some people going on very important trips, very remote areas, they may wish to consider having that. It's an oral vaccine. It doesn't have any particular side effects. It's dead. It doesn't make any problems with any of the other live vaccines. So that may be something to consider for people. It's not suitable in kids because kids can't drink it. It tastes disgusting. We've talked about Japanese encephalitis. Japanese encephalitis is now, of course, in Australia, and it means that when we have that discussion with travellers, they'll often say, yes, I've heard about this. And because they're living in Australia, they will have a bit more of an understanding of this. And so some of them are more likely to have the vaccine. Particularly, as Sarah has pointed out, if you think about someone's future travels, if someone's going away for a month several times, then that adds up to a lot more time than if they're just going for one trip. And we now have this tool called the Japanese encephalitis vaccine tool, which is available at this website, vaccical.com. And you can enter with the patient where they're going, how long they're going for, or their age and demographics and so on. And it will give you a precise calculation of their risk of Japanese encephalitis. So it can help people decide whether they want to get the Japanese encephalitis vaccine. So with her, probably would not give Japanese encephalitis vaccine to her, but it's something to discuss with the parents. The alternative to having a Japanese encephalitis vaccine is, of course, just to take care with mosquitoes. And if you're a very small child, it's a bit easier to keep them under a mosquito net covered in mosquito repellent and so on. Tick encephalitis is really a disease which is underappreciated in Australia and by Australian travellers. This is a very serious disease in Europe. In Austria, it's part of the routine vaccinations. Everybody in Austria gets it. My daughter rang me and said, I had this friend, I've just discovered she's been bushwalking all through Europe and she's come down, she got a tick bite, now she's feverish and got a headache. And she was quite cross that this friend never asked her about travel vaccines before she went to Europe. But this is a very, very common story. People just don't think about it. They don't know about it. They don't know to ask. The brochures don't have this. But if you were bushwalking for, a month or two in Europe and you were living in Austria, they wouldn't dream of not letting you have this vaccine. So it is something you need to think about. It may be something you want to refer to a travel clinic because it is a more specialised vaccine, but it is something that needs to be discussed. This disease really does happen. It's mainly, like Japanese encephalitis, dangerous in the elderly, but it can be quite miserable to catch even in the young. And these are the areas where it's kind of yellow. Then we talk about rabies. These lovely dogs are everywhere when people travel. This is Mongolia. This is just outside the yurt, local dog, and we've talked about this already. And those of you in my age group will know that this is the robot from Lost in Space saying, danger, Will Robinson, danger. It's very dangerous to say to people, oh, just don't pat dogs, you'll be fine. Or, oh, it's only a short trip, you're only going for a couple of weeks. Short trips and not patting dogs are no predictors or guarantee of not getting a rabies risk exposure. The activity leading to bite was looked at in a study we did, and some of it was taking a photo. I had a patient who was taking a photo of a monkey, and the monkey ran around and bit her 3-year-old. Barley is particularly bad, which I'll talk about in a sec. Now, this is the old rabies vaccine, the Semple vaccine. We went to the rabies manufacturing plant in Madras, and if you look carefully, you can see the head of the, there's the eye of the sheep and the teeth. And they basically deliver these ram's heads with rabies-infected brains, and they process them and turn them into rabies vaccine. So this is not the modern rabies vaccine that we know and love. And getting vaccinated in some countries can be a bit difficult. Mostly around the world, they will have the normal rabies vaccine. But getting the rabies immune globulin, as Sarah has pointed out, is very difficult. Now, I just wanted to talk about barley. Barley is a real problem, because people just go off to Bali thinking it's all going to be peachy. And these Bali monkey forests, some studies have suggested 8% of people going to the monkey forest get a bite. I've had people carrying a stick through the Bali monkey forest, put the stick down, then get bitten. I've had people with monkeys on their back pulling at the bra straps, stealing glasses, stealing phones. I had one lady bitten in the car park because she didn't want to go in because she heard it was dangerous. Getting vaccinated in Bali is difficult. And the other problem with Bali is this monkey bee virus. But this is a couple of pictures. This lady was just standing there. You can see in the red circle, the monkey just came, bit her on the elbow. This lady was feeding and the monkey just bit them. People just don't realise. And of course, this is expensive and annoying. And then there's the issue of the monkey bee virus. They have studies in the workers in these forests showing that some of them have been exposed to the monkey bee virus, and there's no tourists so far. Monkey bee virus is a type of herpes virus which can cause encephalitis and death, and it's happened mainly in people who are looking after monkeys in a laboratory setting. But if you get bitten in Bali and you go to the local doctors, they will offer you a cyclovir at vast expense to the management to stop this monkey bee virus, which causes an awful lot of stress. People will come to me and say, do I really need this? It's not actually very clear whether this will work. Thankfully, there have been no cases of monkey bee virus in tourists, but it causes a lot of stress, which all disappears if people just do not get a monkey bite. Anyone who's going to Bali, they need a little chat about monkeys in Bali and how dangerous it is and how annoying it is if they get bitten. There was one family who went to Bali, you know, landed, booked into the hotel, went for this lovely walk along the beach. Dog runs out, bites the child, try to get the vaccine, can't get the vaccine, bundle themselves up back to Australia to get, of course, a rabies vaccine. It's extremely disruptive and it's forgotten. Everyone worries about Bali belly, but they just don't think about rabies. So please, please warn your patients who are going to Bali to keep away from the monkeys, do not let themselves get bitten. It happens in a flash and can really destroy their trip. We've just talked about. So with her, this little child, we're not going to give rabies vaccine to her because she can be looked after very carefully by the parents, so she won't need to have rabies vaccine. But if she were bitten, then she would need to have the vaccine. Q fever, I think, is something you should think about as part of your travel consult. If someone is going to be working or interacting with animals. I had a lady who was going to Costa Rica to look into caring for animals, and it turned out she was working for Australia Zoo. And when I raised it, she said, oh yeah, they've been telling me I should have a Q fever vaccine. So it's something that if you don't think about it, it'll just get overlooked. And I'm sure you're aware of the Q fever risk factors, but it's basically from animal exposure, particularly animals having offspring. And the last one on the list is the leading infectious disease killer in the world, which is always forgotten, and that is tuberculosis. And multi-drug resistant TB is on the rise. We're losing the battle with TB. It is a forgotten disease in Australia because we don't see it very much. We don't diagnose it very much, but it's really surging around the world. And if you look at the BCG policy by country, it's only a small number of countries in the purple there which don't give BCG at birth. So many of your VFR children will be going back to these countries and they will be taking very small children, and all the locals are vaccinated, but your patients will not be. So it is very important to raise this point with your VFR patients. The BCG is a very old vaccine. It's over 100 years old, and it was made under great duress during the war. They actually, Camet and Gorin had to kind of keep revitalizing the culture every week, and they did this 230 times, and they had to use ox blood, which they couldn't get because of the World War I. And they had, Camet had to actually treat the Germans for typhoid, which he was very dirty on because the Germans had taken his wife away to a concentration camp. But it's all we've got. We don't have anything else at the moment. It still works, you know, remarkably well for small children. The rate is less than 1% per traveller per year, but it's very much dependent on the traveller. And under 5 years old is a particular risk group. Obviously, smoking, diabetes, any other immunosuppressive conditions will increase your risk of TB. But you can't really vaccinate older people. You can only vaccinate them under the age of 5. And this is what the Australian Immunisation Handbook says: age, incidence of destination, duration of travel more than 3 months, and proximity of contact. Now, duration of travel has to be thought about with respect to their total, not just this one trip. This is the age, and you can see up to the age of 4, there's a much bigger peak for TB than in the other age groups, but it does still occur. And you can get maps like this where the incidence of destination is listed, and you can see India, Pakistan, the Indian subcontinent, and Indonesia are high risk for TB. And that's where a lot of our VFR travellers are going. New South Wales Health has a very nice website where they actually which lists the TB incidence of 40 cases per 100,000 and tells you which countries you need to be vaccinating people. And we did a kind of audit, if you like, of 143 BCG babies who came in. And this was the number of weeks of their first trip. So most of them were going on a very short trip the first time, but they were going back repeatedly. So don't just think about the first trip, think about all their trips that the child will have before the age of 5. One of the important things about the medical history is whether they've been outside the country yet. If they have, they need to have a MAN2 test before they have a BCG. And the BCG does take 3 months to work. It doesn't work immediately. But the most important thing is this case report where a child had a BCG and got fatal disseminated BCG infection because the mother, the mother had been taking immunosuppressant drugs. So under 6 months of age, you need to ask the biological mother if there's been any immunosuppression. This is the MAN2 test. I'll whip through these slides now just to show you. There is also a quantiferon test you can have for seeing if someone's had exposure to TB. We do some counselling with the parents. You may see people come in who've had a BCG. It looks pretty nothing for the first couple of weeks, and then it can look really quite horrible. This is normal behaviour for a BCG, nothing to worry about. Just want to flag, if you ever see this in a BCG site 6 months afterwards, you need to think of Kawasaki disease. Kawasaki disease has a nasty tendency to do this to BCG sites. And so this child, we're going to try and give a BCG. Now, with the BCG, we have to be careful with timing because it's a live vaccine. So once you've done your vaccine schedule, you need to check that all the live vaccines are given either together or a month apart, because otherwise they can interfere with each other. Also, just a reminder, if anyone misses a vaccine, they don't have to start again. They can just pick up the schedule where they left off. You don't recommence. The immune system is not impaired by delay. Now, I'm just going to whip through a couple of other things to think about with travellers. Think about deep vein thrombosis. Think about altitude sickness. You may need to talk about malaria. Dengue fever has been increasing. You look at the difference between 1994 in the red and 2001 in the red. Dengue is surging around the world. Sexually transmitted diseases should also be discussed with people. This says he won't be wearing this, so you need to make sure he's got a condom. Safe food is very important. This was on a table in a smorgasbord. It says smoke black crap. I think they meant carp. There's all these travel doctors trying to take the picture. Food is not always safe. They don't have nice public health infrastructure, as I showed you before. This lady was changing her baby's fecally stained nappy in amongst all this meat. This was going off to be eaten. And this kind of beautiful salad is Russian roulette. Ciguatera is something that needs to be thought about. I've had some really sick patients with ciguatera from the Pacific going on fishing trips. Gastro is pretty miserable. This person couldn't get out of the toilet. This is my daughter who agreed to take this, have this picture shown. Fake drugs are a worry, so you need to see if people can carry a little medical kit with them. There are other parasites like gigafleas and so on, which can be picked up in some parts of the world. Encouraging people to be fit beforehand is very important. They're going to do a lot of activity, which can be quite wearing. Accidents are one of the biggies, and half of the accidents are on pedestrians. So just a mention about car accidents. Having insurance is important. This is not the greatest ambulance you'd want to rely on. And having a little book to read about all this stuff, because there's a lot of stuff. And we do also have an app that people can look up their symptoms. So I just want to finish with saying my suggestion is people often ask me, who should I refer? Maybe special vaccines, yellow fever, Japanese encephalitis, tick encephalitis, BCG, maybe even dengue vaccine. Unusual or unfamiliar destinations, complicated itineraries, young children, people with unstable conditions, particularly HIV, and pregnant travellers to malarious areas. So I'm very happy to take questions. We love travel. It's a fun thing to do, but if you can be systematic about how you approach it, then you're not going to forget the basics, and then travellers will be much safer. Thank you.